Welcome to Series 1, Episode 3. I'm Trudy Loban, the founder and CEO of the AF Association and Arrhythmia Alliance, and joining us today is Professor Gregory Lipp, a medical advisor to our organisation and an expert in atrial fibrillation. So today, where we have AF is as easy as A, B, C, today's episode, part 1, will feature on B, for better symptom control. Welcome, Greg.
Thank you, Terry. So for today's episode, we're going to focus on the B, which is better symptom control or better symptom management. And I mentioned earlier that there are two broad strategies, and I do mention broad because it's heart rate control or heart rhythm control, sometimes referred to as rate control or rhythm control. Now, the research studies that have tried to compare one strategy to the other, they both show that either strategy is similar in terms of patient outcomes in the long term. So ultimately, we are focused again on the patient, and we are largely trying to improve or optimize the patient's symptoms. Now, about a third of patients with atrial fibrillation have no symptoms. So that's a starting comment to make. There are other patients who would have symptoms such as palpitations or breathlessness, sometimes chest discomfort, a reduction in their exercise capacity. And all these questions will need to be assessed and addressed when managing our patients. Now, in terms of the physician assessing the patients, there is something called the ERA score, and European Heart Rhythm Association score, which is a measure of the patient's symptom status, with 1 from mild or no symptoms ranging to 4, which are very symptomatic patients. So ultimately, as mentioned, the priority is to largely focus for most of the AF patients to manage their symptoms. With heart rate control, this may be a reasonable option in many patients because, as already stated, a third of patients have no symptoms anyway. So it's a bit hard to improve on no symptoms because if they haven't got any symptoms to start with. There might be patients who get a sensation of palpitations or the heart racing. Well, an appropriate drug to control the heart rate is therefore indicated. And in the NICE guidelines and also many of the international guidelines, the general recommendation is to consider starting with a beta blocker or a rate-limiting calcium channel blocker. And what do I mean by that? That's usually verapamil or diltiazem. And of course, the choice also depends on the patient clinical risk factors or characteristics, whether one drug or the other is appropriate. Now, in elderly patients with atrial fibrillation who are perhaps more sedentary and is to consider digoxin, and this is a drug that has been around for a very long time. And yes, this controls the heart rate at rest, although some of the studies suggest it doesn't control the heart rate so well if there's a very physically active and a patient with atrial fibrillation. What we tend to do when trying to optimize heart rate control, if they're already on a beta blocker or a rate-limiting calcium channel blocker, is to consider the next option or the second line to add in digoxin as a combination, and where a digoxin with a beta blocker or digoxin with a calcium channel blocker, it does offer additive value to control the heart rate. Now, beyond that, it all starts getting more complex. And really, if there's challenges to control the heart rate, even with combination therapy, maybe a specialist referral or discussion would be appropriate, because you're now getting into the realms of trying to have combinations of 3 drugs, which is not impossible, but has to be done very cautiously. In some patients, there might be even the necessity to even consider an antiarrhythmic drug called amiodarone. This is on top of some of the other drugs that I mentioned. But in all seriousness, this is really something for a specialist clinic discussion. And if that still doesn't work, we're now talking to something more complex, requiring even an electrophysiology procedure and possible pacemaker implantation to regularize the heart rate. So these are the different scales or levels. But for the majority of atrial fibrillation patients, we are really trying to help symptom management, and usually drugs in combination, simple combinations, would do the trick for most patients.
So you would commence with this line of treatment after they've been anticoagulated to reduce their risk of an AF-related stroke. You would then look at rate control.
Absolutely.
Yes, yeah, and the vast majority of patients respond well to that.
Absolutely, but it's just to stress again that the approach or the steps are very patient-centered, because if the patient and the third of the population of AF patients has no symptoms, well, it's a bit hard to improve on no symptoms. So it's no point adding a beta blocker and slowing down the heart rate even more. One trial did try and study the effects of aggressive heart rate control versus more lenient heart rate control. And in terms of the clinical outcomes related to one strategy or the other, there was no significant difference. So emphasizing again, a very patient-centered and symptom-directed approach to the decisions about rate control, or as we'll cover in the next episode, rhythm control.
I think it's really important, and hopefully the number of patients that will view this series will better understand, so they can also have an informed discussion with their clinician as to the best treatment option and the steps for them. So Professor Lipp, thank you so much, and we look forward to looking at the next episode on rhythm control. Thank you.
Thank you, Trudy.